Greetings, one and all. On behalf of MEU India, I welcome you all to today's session in Dr. Sambit Memorial Lecture Series. The speaker of today's talk needs no introduction. He is a world-famous geopathologist and a dear friend of me, as well as late Dr. Sambit Mohanty. Please welcome Dr. Martin Acosta. Dr. Acosta is currently working as geopathologist in Indiana University. He completed his medical school from Argentina and then moved to US to pursue residency in anatomic and clinical pathology from University of Chicago, followed by fellowship in genitourinary pathology from prestigious Harvard Medical School, Boston. He also worked as faculty there. He is leading figure in testicle pathologies and has published widely and is acknowledged widely for his extensive research on testicular tumors and has published numerous papers as well as book chapters in prestigious books including WHO and Fletcher's histopathology. His areas of interest include non-germ cell tumors and clinically aggressive phenotypes of germ cell tumors of testes not responsive to therapy. Today he's going to speak on sex cord stromas of testes, and without much ado, I'll request him to take the stage and enlighten us with his wisdom and extensive expertise. Thank you, Dr. Costa, for being here.
Thank you very much for the very nice introduction, Seema, and it's truly my pleasure to be here with you all and giving this relatively short talk on general considerations and recent advances in sex cord stromal tumors of the testis. I have no conflicts of interest, but before I start, I would like to remind everyone the reason why we're here, and that is to honor our colleague and personally my friend, Dr. Sambit Mohanty, who was truly a brilliant genitourinary pathologist and a wonderful person, and he left us half a year ago today. So the whole purpose of this is not only to talk about sex cord stromal tumors, but to honor Dr. Sambit Mohanty. So in this lecture, we will basically...
I'll have to mute everyone.
Can you hear me?
Yes.
Oh, sorry. So in this presentation, we will go over the basic clinical features, the gross pathology features, histopathologic features, risk assessment, molecular features, and recent recommendations for the three most common types of sex cord stromal tumors that at least we see in clinical practice here in Indiana, which are Leydig cell tumors, Sertoli cell tumor, NOS, and large cell calcifying Sertoli cell tumor. And I will try to finish with some general take-home messages and conclusions. So we'll start with the most common sex cord stromal tumor overall, that is Leydig cell tumor. And this represents about 3 to 5% of all testicular tumors, although the proportion might be higher in children because in children, of course, germ cell tumors are less common. The incidence is biphasic, with about 20% of cases occurring in prepubertal children and the remaining 80% of cases occurring in adult patients, typically middle-aged to elderly adults. And the clinical presentation is different in these two populations because these tumors produce hormones. Of course, in children who are prepubertal, they will typically present with precocious isosexual pseudopuberty, which can be present with or without gynecomastia. Whereas in adult patients, we often see a presentation that's characterized by the presence of a painless testicular mass rather than by the effect of sex hormones. Regarding the clinical behavior of these tumors, the vast majority of them, probably 90 to 95% based on the data that's published, are indolent and therefore are cured with surgical resection. But there's a subset of about 5 to 10% that metastasizes and behave very aggressively. And so far, this has only been described in adult cases, not in children. And this subset of cases that are malignant are quite problematic for two reasons. The main one is that they don't respond to systemic treatment, or at least to the systemic treatments that we currently have available. And the second problem is that a subset of these malignant cases will not have worrisome histopathologic features, and therefore it can be hard to predict when they are going to metastasize. And the fact that the disease-specific mortality pretty much parallels the percentage of malignant cases is reflecting that once these tumors become malignant and metastasize, their prognosis is pretty poor. Grossly Leydig cell tumors that are typical, meaning that are benign, are characterized by well-circumscribed nodules with smooth borders and homogeneous cut surface that tends to be yellow due to their high lipid content. They may have small petechiae or areas of hemorrhage, but large areas of hemorrhage and necrosis are not common, especially among benign tumors, of course. And microscopically, when we look at these tumors at low to intermediate magnification, they tend to have this sort of like syncytial pink appearance, and that's because they have a minimal amount of stroma, and they tend to grow as solid sheets. And also, if we look at these tumors at higher magnification, we'll notice that the cell membranes are pretty much imperceptible or very delicate. That also contributes to this syncytial appearance that we typically identify at low to intermediate magnification. As you can see in these pictures, the tumor cells are characterized by the presence of abundant bright eosinophilic cytoplasm that is typically granular, and the cell nuclei are round and regular with a single nucleolus that can be centrally or peripherally located, and it's typically visible at 10x. Other features that are quite common, and you can see in these pictures, are the presence of lipofuscin pigment, and this is most likely a byproduct of the lipid metabolism that these cells have, and the presence of nuclear pseudoinclusions, where these pseudoinclusions have the same characteristics as the surrounding cytoplasm. And by the same characteristics, I mean the same granular texture. But that's different from another feature that is quite useful for this diagnosis, and we find quite frequently with this, which is the presence of this homogeneous ground glass chromatin that you can see here and here, where you have this sort of like homogeneous pink staining of the nuclei that is not granular as you would expect in a pseudo inclusion, as I've shown in the pictures in the prior slide. But of course, what we all want to find to make a diagnosis of Leydig cell tumor is the presence of Reinke crystals, because this is a pathognomonic finding for Leydig cell differentiation. And Reinke crystals are these rod-shaped, bright eosinophilic crystals that we find in the cytoplasm of the Leydig cells. Some of them are highlighted by the arrows in these two pictures. But keep in mind that Reinke crystals are pathognomonic for Leydig cell differentiation, but not necessarily for Leydig cell tumor, because we may also find them in benign Leydig cell proliferations, such as nodules of Leydig cell hyperplasia, such as the ones that I'm showing here that were present in our orchiectomy that was performed for germ cell tumor. Other findings that are quite common are the presence of intracytoplasmic or stromal hyaline globules that are bright eosinophilic, as you can see in this picture. And of course, we have variations in morphology. Some tumors, as the one you see on the left, may have a little bit of the typical Leydig cell tumors, and also we have a change that we call lipidized Leydig cell tumor, or lipidization of these tumors, in which the tumor cells are completely filled by lipid microvesicles, as you can see in these two pictures. And as you can see on the left, this change can be focal, or as you can see on the right, it can be quite diffuse in some cases. And this can be problematic, especially when these tumors show up in metastatic sites, because you may have to rule out some other tumors with overlapping morphologies, such as an adrenocortical carcinoma. Other morphological variations that we see in Leydig cell tumor quite frequently is the presence of multinucleate tumor cells, as you can appreciate on the left, and the presence of areas with spindle cell morphology, as you can see on the right. And I've seen some tumors that have predominantly spindle cell morphology, and this tend to be aggressive. Regarding immunohistochemistry, as you may know, the markers that we use for sex cord stromal tumor, or at least most of them, are not entirely specific to distinguish between the different types of sex cord stromal tumor, with some exceptions that we will see later on. But from a practical perspective, the most useful markers for Leydig cell tumors are inhibin and SF1, both of which will stain more than 95% of the cases, whereas calretinin, SOX9 have lower sensitivity. And the markers that we use to demonstrate sex cord differentiation, which are mostly WT1 and FOXL2, also to some degree SOX9, Leydig cell tumor, and in particular WT1 and FOXL2 are negative in more than 90% of the cases, so they are not very useful in clinical practice, just to show if you want to just highlight a Leydig cell tumor. One thing to keep in mind is that Leydig cell tumors may express melon A, and they may also express keratin, S100, and some neuroendocrine markers such as synaptophysin. And expression is typically focal, but again, this can be problematic and potentially a pitfall when these tumors show up in metastatic sites. And keep in mind that Leydig cell tumors express AR, although I don't use this stain in clinical practice, mostly because many tumor types in the testis will express AR. I can only highlight one instance where this can be useful, and that is when we want to differentiate a testicular tumor of the androgenital syndrome from a Leydig cell tumor. So that's probably the only instance where I would use AR for this tumor type. And of course, these tumors are consistently negative for markers of germ cell tumors, and that can be occasionally helpful when we are considering in the differential diagnosis some rare variants of germ cell tumors that show morphologic overlap with Leydig cell tumors, such as the hepatoid variant of yolk sac tumor. But of course, these tumors span a spectrum, and malignant cases can have significant nuclear pleomorphism, as I'm showing in these two examples of malignant Leydig cell tumors that show this marked nuclear atypia with very large nuclei that contained dark, clumpy chromatin. And we have to distinguish this type of nuclear atypia from the degenerative atypia that we may find in benign Leydig cell tumors or even in normal neuroendocrine organs that's characterized by a dark but homogeneous chromatin, and you may be familiar with that. These tumors, again, may have also big nucleoli that is typically present with this marked nuclear enlargement, but keep in mind that some Leydig cell tumors that are clinically malignant may not have that degree of nuclear atypia, as the cases that I'm showing in these two pictures, where you can see that these tumors do not show significant nuclear pleomorphism, although on the left you can appreciate that there are three mitotic figures within a single high power field. And on the right you can see another feature that I personally find quite useful for identifying malignant cases, which is the presence of scattered apoptotic foci and the presence, of course, of coalescing foci of apoptosis and tumor necrosis, which is not something that you would expect to find in benign Leydig cell tumors. But again, as I've mentioned before, one of the problems with Leydig cell tumors and with most sex cord stromal tumor types is that their behavior may be difficult to predict based on their histopathologic characteristics, because there's a subset of cases that are clinically aggressive and don't have aggressive histopathologic features. And that's why for these tumors, we need to use multiparametric systems. And the multiparametric system that's published in the WHO and has been the one that's been traditionally used includes the 5 parameters that are highlighted by this red box here. And you can appreciate that the cutoff for the mitotic rate is more than 3 mitoses per 10 high power field. And the cutoff for tumor size that has been traditionally used is 5 centimeters, although now we know that this might be too high of a threshold, because tumors that are smaller than this are probably potentially malignant, as well, as we will see in the studies that I'm going to show next. And recently, well, somewhat recently in 2020, this large study of more than 1,000 patients, including all cases reported in the literature, was published as a meta-analysis demonstrating that about 10% of all Leydig cell tumors, at least of those published in the literature, are malignant. And when they metastasize, they tend to metastasize to retroperitoneal lymph nodes in about half of the patients, to the lungs in over a third of the patients, and to the liver in a little bit over a fourth of the patients, whereas metastases to other sites are quite rare. And using data from these published cases in univariate and multivariate analysis, the authors of the study identified factors that were associated with higher risk of metastasis and that were associated with lower risk of metastasis. So among the risk factors for metastasis, they found that age with a cutoff of 42, tumor size with a cutoff of 3 centimeters, and the presence of any worrisome histopathologic finding or any histopathologic risk factor were all independently associated with a higher risk of metastasis. Whereas the presence of any of 3 protective factors, which are the presence of Reinke crystals, lipofuscin pigment, or gynecomastia, were associated with a lower risk of metastasis. And therefore, combining these different factors, they created a multiparametric risk score. And in this risk score, you can appreciate that the combination of two or more of any of the risk factors is associated with a significant risk of malignant behavior, but also in this model at least, the presence of tumor size of more than 3 centimeters alone is associated with a risk of metastasis that goes between 40 and 50%, and the presence of an age older than 42 years alone, or the presence of any adverse histopathologic finding alone are associated with a risk of metastasis between 30 and 40%, which is pretty high. And therefore, according to this model, the only Leydig cell tumors that can be safely interpreted as benign are those that don't have any adverse features or any risk factors, or alternatively, those that have only one risk factor, but also have concurrently some of the protective factors present. But here I want to point out that I think the model here is subject to significant bias because, of course, for an entity that we've known for 100 years, most of the cases that are going to be published in the literature are going to be the malignant cases, not the benign cases. And that's why I think age seems to be a significant risk factor. And that is because most malignant cases occur in adult patients, although I would argue that the age of 42 years or more alone does not confer a risk of metastasis between 30 and 40% because we see Leydig cell tumors that are indolent in adult patients all the time. So keep that in mind if you're planning to use this risk assessment tool. The one that I personally use is the score published by Maurizio Collecchia and colleagues that is called the Leydig Cell Scale Score. That is also a multiparametric system that includes number of mitosis, size, necrosis, presence of infiltrative growth, and the presence of vascular invasion, and assigns points to each one of these findings, creating a score that goes from 0 to 7. And in the initial study that they published, they show that all indolent cases had scores that went from 0 to 3, whereas all tumors that had scores of 4 or higher were clinically malignant. So currently, I'm using this in clinical practice, although it's not validated yet. And from a molecular perspective, Leydig cell tumors in children with precocious isosexual pseudopuberty are pretty much always, at least based on what we know, driven by a hotspot mutation in codon 578 of the luteinizing hormone receptor gene that leads to activation of this gene and the downstream signaling pathway. But that is not what we see in adult Leydig cell tumors, which typically don't have any mutation in the luteinizing hormone receptor or the downstream components of the signaling pathway. But instead, in this study from several years ago, this group found that 2 of 29 cases in adult patients had FH mutations with FH inactivation, and one of these 2 patients had a known history of HLRCC. And more recently, molecular analysis that have focused specifically on clinically malignant, that is metastasizing cases, have shown that MDM2 amplification is a recurrent event in this subset of cases, being present in 30 to 40% of the cases in this 2 series. And this means that we can use this as a marker for potentially aggressive Leydig cell tumors because we can detect MDM2 overexpression, which is a surrogate marker of amplification by immunohistochemistry, or if you have FISH for MDM2, you can detect the amplification directly. And again, this can be potentially useful for primary tumors with aggressive features to predict the possibility of malignant clinical behavior. And more recently, analysis with next-generation sequencing of Leydig cell tumors, including aggressive primary tumors, metastatic tumors, and primary indolent tumors, have recognized that there are 3 genomic subtypes. One of them that's characterized by the presence of FH inactivation, the other one that's characterized by activation of the WNT pathway, and a third group that doesn't have any recurrent mutations, but instead shows significant chromosomal aneuploidies, including amplification of oncogenes and biallelic deletions of tumor suppressors. So let's start with the group of FH deficient Leydig cell tumors. And one thing that was observed in the study was that FH deficiency is in fact enriched among primary tumors with aggressive histopathologic features or clinically malignant tumors, arguing again that FH deficiency could be a marker of malignant potential in primary tumors. And interestingly, at least 2 of the variants that were found in the study were characterized as of germline origin in ClinVar, meaning that they can be associated with HLRCC, although in this study there was no germline analysis. And of course, as you may know, there's a very good antibody for FH, and this can be detected in our daily practice using immunohistochemistry, as I'm showing here in one example of an FH-deficient Leydig cell tumor with loss of expression in the tumor cells and retained expression in the internal control that in this case are the endothelial cells of the capillaries. In the second group that was characterized by absence of recurrent mutations and widespread chromosomal aneuploidies, you can see that there are cases with MDM2 amplification and typically with CDK4 co-amplification, as it was described by the groups in Italy. And what's interesting is that one of these 2 tumors was a primary tumor with aggressive histopathologic features, again arguing that the use of MDM2 immunohistochemistry or MDM2 FISH in primary tumors with aggressive features may be useful to predict the malignant clinical behavior in these cases. And this is important because in the original series where MDM2 amplifications were described, they were only described in metastasizing tumors, not in primary tumors. And finally, the third group, which was characterized by evidence of WNT pathway activation, and this included not only malignant cases or primary tumors with aggressive histopathologic features, but also primary tumors with indolent features, was characterized mostly by gain-of-function beta-catenin mutations, but also in a rare case by allelic inactivation of APC. And interestingly, as you may know, beta-catenin mutations tend to cluster in exon 3, and that's because exon 3 codes for a very important region of the N-terminal domain that spans amino acid residues 32 to 45 that contains multiple targets for phosphorylation by CK1 and JSK3 beta. And phosphorylation of the sites will typically mark the protein for ubiquitination and degradation in the proteasome. And as you can see in this table on the left, pretty much all of the mutations that we found in Leydig cell tumors were within this critical domain. And what's interesting is that when we looked at the cellularity of the Leydig cell tumors and the variant allele frequency of the beta-catenin mutations, we noted that most of these mutations are present as subclonal events, meaning that they are only present in subsets of the tumor cells rather than in every tumor cells, as we will see is typically found in Sertoli cell tumor NOS. And in fact, in a follow-up study, it was shown that nuclear expression of beta-catenin is quite common in Leydig cell tumors, being detected in 47% of these 32 cases. And in 4 of 7 cases that had additional material, it was demonstrated again that there were hotspot beta-catenin mutations or exon 3 beta-catenin mutations at variant allele frequencies suggestive of a subclonal event. And what I mean by a subclonal event is exactly what I'm showing in this micrographs with beta-catenin immunohistochemistry in this Leydig cell tumor, where you can see that instead of having nuclear expression in every tumor cell, you'll only have nuclear expression in subsets of tumor cells. And another group has described the presence of recurrent TERT fusions with different partners in malignant, and that is metastasizing Leydig cell tumors, although we recently used RNA sequencing in a subset of aggressive tumors, and we could not replicate these findings. And based on all these new molecular findings, there has been a recent consensus meeting of experts in testicular tumors that has come up with and workup of testicular sex cord stromal tumors. And in particular for Leydig cell tumors, it's been proposed that those with FH deficiency should be classified separately as FH deficient Leydig cell tumor to highlight that they are FH deficient, which may lead clinicians to perform genetic tests if necessary to assess the germline. And regarding the workup of this tumor, it's been recommended that primary tumors with aggressive histopathologic features be tested for FH with immunohistochemistry and MDM2, either with immunohistochemistry or FISH, to identify those tumors with aggressive or malignant potential. And finally, in metastatic tumors, it's recommended that we do FH not to predict malignant potentials, because by definition, these tumors are already malignant, but to detect FH deficiency, which again may lead the clinicians to do further assessment of the underlying genomic alterations in these patients. We'll go into the next tumor type, which is the second most common sex cord stromal tumor type in the testis, Sertoli cell tumor NOS. This is less frequent than Leydig cell tumor and represents about 1% of all testicular tumors. Affects patients of all ages, but more typically adults. And in fact, the median age of presentation is 39 years. And like Leydig cell tumors, 90% are benign and 10% are malignant, although the fraction of malignant cases in some series has been significantly higher. And a significant difference here with Leydig cell tumors is that there have been rare malignant cases reported in children, whereas, as I mentioned before, Leydig cell tumors in children seem to be invariably indolent. They typically present as a testicular mass, although they can present with gynecomastia. And in children, this can present as isolated gynecomastia. And that's a difference with Leydig cell tumors, because in Leydig cell tumors, when gynecomastia is present in children, it's also always present in the context of precocious isosexual pseudopuberty. And another thing to keep in mind is that these tumors have been reported as being discovered incidentally in men that are undergoing workup for infertility or impotence, and it is thought that this is most likely due to the production of estrogen by these tumors. Grossly, again, they tend to be well circumscribed nodules. And here, the thing to highlight is that about 30% of Sertoli cell tumors NOS will have cystic changes, and sometimes you can see this grossly. Microscopically, these tumors, as you can appreciate in this picture, tend to have much more stroma than Leydig cell tumors, and that stroma is typically collagenous or fibrous, more typically collagenous than fibrous. And you can appreciate that they pretty much always have some degree of evidence of sex cord differentiation, and that is reflected by their architecture that includes cores, trabecules, or tubules of neoplastic cells. But of course, what we all want to find, and is sort of pathognomonic, or I wouldn't say pathognomonic, but characteristic of this tumor type, is the presence of tubules, which can be in larger tumors be present only in the periphery, whereas the center tends to be more solid. And these tubules may contain eosinophilic or basophilic secretions, as you can see in the picture on the left. In these pictures, you can appreciate that the cells, compared to Leydig cell tumor, have less cytoplasm, and this cytoplasm is more likely eosinophilic to almost clear, as you can see in the picture on the right. And the cells have round regular nuclei, but the nucleoli are typically inconspicuous at 10x, and that's another difference with Leydig cell tumors. Here you can appreciate that sometimes these tumors may not have hollow tubules, but instead solid tubules and small islands of tumor cells. And Sertoli cell tumors, as I mentioned before, may have cystic change that can go from microscopic to macroscopic, and they tend to have multiple growth patterns within the same lesion. And another growth pattern that is well recognized in this tumor type is the presence of this reedy testis-like structures that we call reediform growth pattern. A useful clue to Sertoli cell tumor NOS, in my opinion, and if you look carefully for the cells, you'll find them in most tumors, is the presence of signet ring cell-like cells. And I say signet ring cell-like cells and not signet ring cells because these cells are univacuolated cells that don't contain mucin. So if you do a mucicarmin stain, these cells should be negative, and that can be sometimes useful when you need to exclude the presence of a metastatic adenocarcinoma to the tested with signet ring cell morphology. Rare cases may have tumor cells with small rhabdoid morphology, and this is not associated with a more aggressive behavior. And there's a subset of Sertoli cell tumors, NOS, that have a very characteristic gross and microscopic appearance. Grossly, they are characterized by this very well circumscribed dense nodules with a white cut surface that can be quite hard or difficult to cut because they are very firm. And microscopically, they are characterized by an abundance of sclerotic or hyalinized stroma that tends to compose more than 50, but up to 80% of the tumor volume sometimes. You can see on the right that in these cases, they may obscure the tumor cell. So this is what we call sclerosing Sertoli cell tumor. Again, a variant or a variation of Sertoli cell tumor NOS. Among the sex cord stromal tumor markers that we use in clinical practice, the most sensitive one is SF1, which stains about 80% of Sertoli cell tumors NOS, followed by SOX9, which stains about 60% of Sertoli cell tumors NOS, whereas the other markers, including FOXL2, inhibin WT1, and calretinin, all stain between 40 and 50% of the cases, so they are not very sensitive. Beta-catenin is somewhat sensitive overall. If you take all benign and malignant cases, sensitivity is about 70%, but if you focus on benign cases, sensitivity goes well above 90%. So this is a very useful marker. And keratins have been reported to be positive in the literature in up to 80% of the cases. I think this is an overestimation. They can certainly be positive, and this is a potential pitfall, but in my experience, they are less commonly positive, probably around 50%, and only focally or multifocally. And of course, the germ cell tumor markers in this tumor type are negative, which can be useful when we need to exclude some rare variants of germ cell tumors that overlap in morphology with Sertoli cell tumor NOS, such as, for example, seminomas with pseudotubular or pseudocordate growth patterns. And meta-analysis of Sertoli cell tumors demonstrated that about 11% of these cases are malignant, and when they metastasize in the overwhelming majority of patients, 3/4 of them, they go to retroperitoneal lymph nodes, followed by lungs in about 1/3 of the patients and bone in about 1/6 of the patients, whereas metastases to other sites are quite rare. And using univariable regression analysis by reviewing cases published in the literature, the authors found that the age with a cutoff of 27.5 years, the tumor size with a cutoff of 2.4 centimeters, the presence of necrosis, extension into the spermatic cord, presence of LVI, and a high mitotic index were all associated with a higher risk of malignant behavior. And Maurizio Colecchia's group demonstrated several years ago now, about 10 years ago, that most Sertoli cell tumors, and in particular pretty much all benign Sertoli cell tumors or primary Sertoli cell tumors without aggressive histopathologic features, show exon 3 beta-catenin mutations. And these mutations, unlike the ones that we see in Leydig cell tumors, are clonal, meaning that they are present in pretty much every tumor cell. And more recently, analysis with next-generation sequencing of clinically malignant cases, that is metastasizing cases, primary cases with aggressive histopathologic features, and primary cases without aggressive histopathologic features, demonstrated that among primary tumors, either with or without aggressive histopathologic features, evidence of WNT pathway activation is pretty much universal, either by gain of function beta-catenin mutations or rarely by the presence of loss of function APC mutations. And this correlates very well with prior studies with immunohistochemistry that had demonstrated that more than 90% of benign Leydig cell tumors show beta-catenin, nuclear beta-catenin expression, whereas this is only seen in about half of malignant Leydig cell tumors. And what this is indicating is that about half of malignant Sertoli cell tumors. And what this is indicating is that about half of malignant Sertoli cell tumors NOS probably are the result of progression of primary tumors with beta-catenin mutations or APC inactivation that then acquire additional genomic alterations such as multiple chromosomal aneuploidies, amplification of oncogenes, or biallelic deletions of tumor suppressors, as you can see in this graph. And again, in this tumor type, beta-catenin mutations are clonal. And what I mean by clonal, again, is present in every tumor cell, and that correlates with diffuse nuclear expression of beta-catenin, as you can appreciate here in comparison to the nuclear beta-catenin expression that we typically see in Leydig cell tumors, where these mutations are subclonal. And just keep in mind that there's a subset of tumors. Well, there's a small group of reports of these tumors being associated with familial adenomatous polyposis coli, and we also analyzed a subset of our APC mutant cases. And in these cases, what we did was to sequence in parallel non-neoplastic and neoplastic tissue, demonstrating that the presence of a germline APC variant with loss of heterozygosity in the tumor is the driver in these tumors, meaning that a subset, probably very small, of Sertoli cell tumors, NOS, may be driven by germline APC mutations and therefore be associated with FAP. In two of these cases, the lesions were either multifocal or bilateral. And in sporadic Sertoli cell tumors, NOS, that would be exceedingly rare. So if you ever see a multifocal or a bilateral Sertoli cell tumor, NOS, you may think about the possibility of an association with a germline APC mutation and therefore do genomic testing of the tumor, or at least discuss this with the clinician. And more than 20 years ago now, the Indiana group, of course, way before I was here, recognized that there's a subset of malignant sex cord stromal tumors that show overlapping features with seminoma, in that they show a purely solid growth and very prominent inflammatory infiltrates. And at that point, they interpreted these tumors as representing malignant examples of Sertoli cell tumor NOS. And when I show you this picture of one of these tumors, you can easily appreciate why many of these tumors were received in consultation with a misdiagnosis of seminoma and were only, after the review of an expert, reclassified as a sex cord stromal tumor. And you can see how that can happen because these tumors have this very dense inflammatory infiltrate that typically includes lymphocytes and plasma cells. But when you look at these tumors more closely, they have a very prominently nested architecture. And in some of the nests, you can have these cohesions of the tumor cells that leads to this pseudotubular or pseudopapillary architecture, which is why I believe they were interpreted as Sertoli cell tumors NOS in the first place. On the left, you can see another very characteristic feature, which is the presence of this very dense collagenous stroma that is present both in primary tumors and in metastases. But compared to seminoma, when you start looking closely at the tumor cells, you'll appreciate that you don't have the typically squared off or angulated nuclei that you see in seminoma, what you would expect in seminoma. And also, these tumors tend to have a low mitotic activity compared to seminoma. So there are some subtle differences. And also, when you focus on the inflammatory infiltrate, you will see that most cases include not only lymphocytes and plasma cells, which may be present or are typically present in seminoma, but also neutrophils and eosinophils, as I'm showing in this picture. And of course, they will be negative for SALL4, OCT4, but instead will express sex cord stromal tumor markers such as inhibin and SF1. And recent molecular analysis of these cases using FISH and next-generation sequencing demonstrated that the overwhelming majority of them show EWSR1, ATF1 gene fusions, or EWSR1 rearrangements if you do the break-apart FISH for this gene. And therefore, given its unique clinical pathologic and molecular features, we now believe that this is a separate entity, and the provisional name that's been given to this tumor type is inflammatory and nested testicular sex cord tumor. So now, among the recommendations for this tumor types, we recommend that all Sertoli cell tumor or all sex cord stromal tumors with overlapping morphology with seminoma, if possible, be tested with EWSR1 break-apart FISH or a test to demonstrate an EWSR1 fusion. This can be RNA sequencing, or if you have the EWSR1 ATF1 fusion fish, you can do this. Again, it's not necessary, I believe, for this diagnosis, but it's certainly desirable. And if you find one of these tumors, we recommend that it be interpreted as a distinct entity. You can, give it the name that we propose, inflammatory and nested testicular sex cord tumor. But the important thing is to highlight that these tumors are malignant. And this is very important because if you call a Sertoli cell tumor NOS in a primary tumor, the clinician may assume that, like Sertoli cell tumors, NOS in general, 90% are going to be benign. Whereas in these cases, it seems to be the case. These cases seem to be invariably clinically aggressive. And the last tumor type that we'll see to the tumor, which is a tumor type that may have both intratubular and invasive components. And in fact, I've seen one pure intratubular case. In the literature, these tumors have invariably associated with the Carney complex with frequencies that go from 10 to 40%, but the majority of them are sporadic. And there are some cases that have been reported in association with the Poy-Jaeger syndrome, although we now believe that most of these cases are likely part of the spectrum of STK11 deficient sex cord stromal tumors that have invasive components and therefore could not be classified as intratubular large cell hyalinizing Sertoli cell neoplasia, which is the typical tumor type that's associated with the Poy-Jaeger syndrome. Of course, syndromic cases, that is those associated with the Carney complex, tend to occur in younger patients. They have a higher frequency of multifocal or bilateral disease, and they are typically associated with isosexual precocious pseudopuberty, with or without gynecomastia, mostly because they occur in young children. And it's been proposed that these syndromic cases also have a lower risk of being malignant. And a subset of cases of about 10% of all large cell calcifying Sertoli cell tumors are clinically malignant. And again, this subset is problematic because there's no perfect correlation with histopathologic features. Grossly, there's nothing too specific about them other than the fact that some of them have been described as greedy when you cut through them, and that's because they have this microscopic calcifications. And the calcifications, which are the typical finding, tend to be laminated in a concentric fashion and have this mulberry-like appearance and can be super abundant, such as in this case, to very focal or even absent in about 20% of the cases. These tumors show evidence of sex cord differentiation in their architecture because they typically show this either trabecular or nested architecture, or even in some cases you can see hint of tubule formation, although in some cases you can have more solid sheet-like growth or large nests of tumor cells. The tumor cells themselves resemble the tumor cells of Leydig cell tumors in that they have abundant bright eosinophilic granular cytoplasm and round regular nuclei. Nucleoli tend to be slightly smaller, but again, there's a lot of overlap. And I think the main difference between Leydig cell tumors and these tumors is the stroma, because the stroma here is myxoid or edematous and typically contains an abundant neutrophilic infiltrate. But again, keep in mind that about 20% of the cases will have more collagenous stroma and will either have focal calcifications or lack calcifications. The general stains that are positive in these tumor types are pretty much the same as in prior cases, with the same pitfalls as I mentioned before. And again, predicting which cases are malignant can be difficult and require multiparametric evaluation. And for that, I can refer you to the study published originally by Shannon Kratzer and colleagues that defined the risk factors for these tumors, which are pretty much the same as for other tumor types, with only the cutoffs being different. But more recently, a validation study demonstrated that, again, predicting behavior in these tumor types can be difficult because there's a subset of tumors with aggressive histopathologic features that never metastasize, and conversely, there's a group of clinically malignant cases that don't have aggressive histopathologic features. From a molecular perspective, two separate studies have shown that PRKR1A inactivation is pretty much universal in this tumor type for the cases that are sequenced successfully. And when you can evaluate loss of heterozygosity, this is also pretty much always present, both in syndromic and in sporadic cases. And this, of course, correlates with loss of expression of PRKR1A by immunohistochemistry, which is a stain that is more well, I wouldn't say it's, widely available, but it's available in many large labs, and it's quite useful for this diagnosis, especially for cases like this one where you have atypical features and that you don't have any calcifications, or the stromal changes that are typical of this tumor types can be only focal. You can appreciate here the tumor that I've just shown, that if you look at it at a higher magnification, you will note that the stroma is sort of myxoid, and it has some neutrophils, but again, it doesn't have any calcifications, and therefore it can be tricky. And in this tumor, you can appreciate that immunohistochemistry is particularly useful. In this case, we used the red chromogen, demonstrating that the tumor has loss of PRKR1A expression. So given that PRKR1A expression loss is pretty much universal in this tumor type, we consider it a desirable, although not a necessary feature to diagnose this tumor type, especially when the tumor has atypical histopathologic features such as the absence or the absence of calcifications, or doesn't have the typical stroma. And so let me finish with some general take-home messages and conclusions. And the first one is that subclassification of sex cord stromal tumor is important for two reasons. The first one is that, as we've mentioned before, some tumors are associated with specific genomic alterations, and some of this may be of germline origin and therefore may require further assessment of the patient and the family. And the other important thing about this subclassifying these tumors is that we know that inflammatory and nested testicular sex cord tumor, for example, is invariably malignant, whereas other tumors are mostly benign. So these distinctions are very important. The second general message is that clinical behavior may be difficult to predict in this tumor type and requires typically multiparametric assessment of histologic and clinical features. And I would say that follow-up is probably desirable in all adult patients with sex cord stromal tumors of the types that I've shown in these presentations. And we strongly recommend not using the terms benign or malignant in reports of sex cord stromal tumors, because of the reasons that we've just mentioned. Sometimes it can be difficult to predict behavior, and there are some tumors that look benign and behave aggressively, and vice versa. And therefore, I personally prefer to use the terms high risk or low risk. And finally, keep in mind that there are no effective systemic treatment strategies for these tumors, which are resistant to pretty much all chemotherapy regimens, and therefore upfront RPL&D is a valid consideration when you have a patient with a primary tumor that has aggressive histopathologic features, because this can lead to the resection of subclinical metastasis and eventually curing a patient that would be otherwise incurable. So these cases are the ones that require further discussion with the clinicians to decide further steps. And that's all I have. Thank you very much for your attention, and I'm happy to take questions if you have any.
Thank you, Dr. Acosta. That was a very informative and comprehensive update, especially in context with the relevant tumor molecular alterations. And we have a couple of questions in the chat box, and I think we have a few minutes. I can take them one by one.
Sure.
Please unmute. Dr. Seema, please unmute.
I think I'm okay. I think I'm unmuted.
Am I audible now?
Yes.
Okay, so we have a couple of questions. The first one is from Dr. Vinod Kumar. He's asking how to differentiate degenerative atypia from malignant DD cell tumor.
Yeah, that's a great question. So in my experience, the most useful thing is the characteristic of the nuclear chromatin. As I've mentioned before, the degenerative type atypia that you will find in Leydig cell tumors is very similar to the degenerative type atypia that you find in normal endocrine organs, right? Sometimes in the adrenal and whatnot, because the chromatin tends to be dark but homogeneous and looks sort of like smudgy. Whereas in malignant Leydig cell tumors with nuclear atypia, the chromatin tends to be like sort of like very clumpy, rather than homogeneous and smudgy. So that to me is the main clue. Also, these tumors that have degenerative type atypia don't tend to have big nucleoli in my experience, whereas nuclei that have this significant nuclear pleomorphism with, dark clumpy chromatin tend to have larger nucleoli. So I think those two clues are somewhat important. Again, if that's the only feature that's present, if you look at most multiparametric score, that's probably not gonna bump you up to a high risk category. That's still, if it's the only finding, it's not the end of the world. If you don't call it nuclear pleomorphism and instead interpret it as degenerative atypia.
Right.
However, if there are other, worrisome features, I think it's something you don't want to miss.
Right. So we have another question from Dr. Padmaja. So it's asking, so how to differentiate steroid cell tumor and leady cell tumor with clear areas morphologically?
Yeah, so in the testis, we don't necessarily use the term steroid cell tumor, or at least I don't. I think the main differentiation that we need to make sometimes is between Leydig cell tumor and the testicular tumors of the androgenital syndrome, and the latter tend to occur in a hilar location. They tend to be multifocal rather than a single mass. And they have been reported to have basophilic stippling in the cytoplasm, which is not typically present in Leydig cell tumors. And of course, the clinical context is the most important thing, because those tumors are typically found in the context of congenital adrenal hyperplasia. So I think that's the main thing. Other than that, I personally don't use the term steroid cell tumor in the testis, but the distinction that we often need to make, or I wouldn't say often, but we sometimes need to make, is between a testicular tumor of the androgenital syndrome, which have a lot of overlap morphologically with these tumors, and Leydig cell tumors. And again, there the clinical context is very important. As I've mentioned before, some people use the combination of synaptophysin and AR because the tumors of the androgenital syndrome should be or have been reported to be negative for AR. But again, clinical context is the most important thing in my opinion.
So we have one or two questions regarding the IHC usage in sex cord stromal tumors. I'll just club them. One of the participant is asking, do you use PRKAR1A IHC as a routine staining for sex cord stromal tumors? Another one, Dr. Santosh is asking, do you use Ki67 routinely while signing out these tumors? And is immunohistochemistry recommended to support the diagnosis of sex cord stromal tumors, or a good morphology is sufficient? So these are a couple of IHC related queries.
Yeah, so regarding PRKI1A, I have it in my lab. So whenever I have a tumor that I think is a large cell calcifying Sertoli cell tumor, or that is part of the differential, I use it. So I guess it all depends on the availability of the stain. If you don't have it and you have a typical large cell calcifying Sertoli cell tumor, I don't think you need it. But for sure, for that 20% subset that doesn't have calcifications or has more solid growth patterns, or it doesn't have the typical stroma, is where PRKR1A can be quite useful to distinguish, especially between a large cell calcifying Sertoli cell tumor and a Leydig cell tumor. One thing that is useful, in my opinion, if you don't have any of the typical features, is the presence of intratubular components. So intratubular components are part of large cell calcifying Sertoli cell tumor, but you don't find them in Leydig cell tumors, because Leydig cell tumors are pure stromal tumors, right? So I think that can be useful. But again, I have it. I use it when I suspect a large cell calcifying Sertoli cell tumor. If you don't have it, I think you can make the diagnosis and you can reserve it for the cases that don't have the typical features. Regarding the general use of sex cord stromal tumor markers, I think that most people who don't work in large centers where they see these tumors commonly could use one or two markers, such as SF1 and inhibin, just to demonstrate that these are, sex cord stromal tumors. I think that's the recommendation that we made in our recent paper that I've shown in some of the slides. And regarding Ki67, I think there's not enough evidence to support the use of Ki67. There's an old study by John Cheville from Mayo from the 90s. I want to say late 90s, sorry. And a recent abstract that was presented by Dan Burney's group at USCAP last year that shows some utility of doing Ki67, but I think there's a lot of overlap between benign tumors and malignant tumors. And there's a gray area. So we don't have a real good cutoff yet. So I personally don't use it. I think I do the mitotic count, which is what's been published, and seems to be more useful.
Yeah. So similarly, Anandi is also asking, is there any prognostic significance of beta-catenin expression in Sertoli cell tumors, and does it help differentiate it syndromic from sporadic cases?
No, that's a really good question. So no, I don't think there is any. I would say this: 90% of benign tumors show nuclear beta-catenin expression. When we looked at malignant tumors, about half of them have beta-catenin expression in the nucleus. So I would say it's more frequent in benign tumors, but I don't think it's useful to make that distinction because there's a subset of malignant tumors that also have beta-catenin expression. And what's interesting is that tumors with biallelic loss of APC also, of course, as expected, have nuclear beta-catenin expression. So beta-catenin expression cannot help you distinguish APC altered from beta-catenin altered tumors. I don't know if that answers the question.
Right. So another question from Dr. Santosh, does your urologist perform testis sparing surgery with FS in these tumors? If yes, is there any size cutoff?
Yeah, I've seen it done for small lesions, typically less than 2 centimeters. It's not the most common thing, but we've seen a couple of cases, especially in young patients, where they will send frozen sections, and these tumors tend to be smaller than 2 centimeters in that context.
Great. So as of
And then
now,
for that particular scenario, I think all you need to tell them is that it's not a germ cell tumor. I don't necessarily think that you need to try to specify which type of sex cord stromal tumor you're dealing with. Just, for the purposes of patient management, just telling them that this is most likely a sex cord stromal tumor, it should be enough.
Right. So quickly, Andy, one question from my side. So do you recommend routine staining for FH or MDM2 testing in all cases of Leydig cell tumor, or do we have any soft morphological indicators where we should go ahead to check for aggressive LCT?
Sorry, you broke up a little bit. Can you repeat the question?
So in case of Leydig cell tumor, do you recommend routine screening by FH and MDM2? Or shall we look for morphological parameters before going ahead with the molecular testing?
Oh, that's a great question. So what we currently recommend is that all primary tumors with aggressive histopathologic features, and by that, depending on I use the less score, but you can use the classical, parameters that I've shown in that red box, in which case you need to have at least 2. For those cases that are deemed high risk in our primary, we recommend performing MDM2 and FH. And for metastatic tumors, again, we recommend doing only FH. The reason for that is that in primary tumors, what you want to try to do is try to predict which ones are going to be clinically malignant. And both FH and MDM2 seem to be useful for that. But once they've metastasized, I mean, you don't care about predicting whether they are clinically malignant or not anymore because the cat is out of the bag. But at that point, you are still interested in identifying FH deficient cases because some of these patients may have a germline alterations that you and the clinicians are not aware of. So that's the recommendation. Having said that, there are 2 cases, and one of them was shared with me by Maurizio Colecchia of primary tumors that were completely indolent based on histopathologic criteria, and then metastasized several years later, and they were discovered to be FH deficient only after they metastasized. And you wouldn't have done the FH based on histopathologic criteria on the primary tumor. So, it's not entirely clear whether all Leydig cell tumors should be tested with FH, in my opinion. And these tumors are so rare that doing FH on all of them, I don't think are going to lead to bankruptcy in any laboratory that has the stain. So I don't think it's a bad idea to just do it in all of them. The recommendation is to do it on primary tumors with aggressive histopathologic features and metastasis for now, but it's something to consider and something that needs further exploration for sure.
Right. So I think that's a great valid point considering the germline implications with FH testing. So I think, and you rightly said that considering these tumors are so rare, so doing FH on an occasional Leydig cell tumor once in this thing is blue moon is not a bad thing. Great. Thank you, Andy, for sharing your wisdom. I don't think there would have been a better person to, enlighten us with all these molecular alterations and updates on sex cord stromal tumors. And Dr. Sambit was passionate about geopathology, and kidney and testicular tumors were his favorite. And there's no other way, I think it's the best way to keep his legacy alive. I thank Dr. Bedi and Dr. Anandi for giving me the opportunity to moderate. And I thank all the participants from all over the world I can see and from all over the time zones, squeezing in between their work schedules to join and actively participate in this initiative. Thank you.
I'm truly thankful for the invitation, and you know, for me, it's an honor to keep Sambit's legacy alive. So hopefully we can do this again in the future.
Right. Great. Thank you.
So thank you
Bye.
from MEUINDIA for this lecture.
Yeah,
Yes.
thank you, Dr. Acosta. Thank you, Dr. Kaushal, for chairing, and a great lecture, Dr. Acosta, I must say. Yes, so I'll just share my screen. Dr. Bedi, for the details of the next lecture, if you could allow me to share my screen.
Yes. I have made you the co-host. Yes.
Yeah,
We can see.
we have our next lecture coming up. That's on the 1st of August. We have Dr. Mahmood Akkul, who will be joining us from Brigham and Women's Hospital, Harvard. And he will be talking on eosinophilic tumors of the kidney. Yeah, so we will share with you the link shortly. Yeah, so please join me. Yeah, thank you.
Thank you, everyone. Goodbye.
Yeah,
Good.
thank you so much.
Thank you, everyone. Good night.
Good.